So I'm very pleased to announce and to introduce today's speaker, Dr. Ketan Shah. Dr. Shah completed his medical and business degrees at the University of Southern California, his combined internal medicine and pediatrics residency at Duke University, and his general gastroenterology fellowship at the University of California, Irvine. Dr. Shah is highly experienced in colon cancer screening and prevention. He is especially interested in high-quality colonoscopy and maintains an extremely high adenoma detection rate. Dr. Shah also employs numerous innovative colonoscopy techniques to achieve higher patient comfort and success rates. And he's currently a practicing general and interventional gastroenterologist with the Saddleback Medical Group in Laguna Hills, California. So Dr. Shah, welcome, and thank you for taking the time to join us today. I will now pass it over to you.
Thank you so much, Kelsey, and thank you all for joining us and allowing me to share with you information on this topic that I feel very passionate about. I hope you all are staying safe and healthy during this challenging time. Can you all hear me okay? Kelsey, is my audio coming through?
Yes, I can hear you well. Yep, you're good.
Well, today we're going to be talking about a new era of colonoscopy. My name is Ketan Shah, and I am a practicing gastroenterologist in Laguna Hills, California. As we all know, colorectal cancer is very common. It's the fourth leading cause of cancer and the second leading cause of cancer deaths in this country. And yet it's one of the most preventable cancer in that we can find and remove colon polyps before they ever turn into cancer. And that early colorectal cancer has a high survival rate, but it is usually detected during screening colonoscopies. And yet 1 in 3 Americans are not screened as recommended. There have been significant efforts and movements to increase the screening rates for colorectal cancer. For example, in 2014, the National Colorectal Cancer Roundtable and the American Cancer Society set a goal of an 80% screening rate by 2018, and this was supported by President Obama's administration. The movements were later updated to the Healthy People initiatives with national goals set in 2020, followed by updated goals set in 2030. And I'm going to share with you a summary of how these goals changed from 2020 to 2030. The focus on increasing the proportion of adults who get screened for colorectal cancer and reducing the colorectal cancer death rate remained unchanged, but there was a slight increase in the focus on detecting Lynch syndrome. By 2030, the goal is to decrease the colorectal cancer death rate from 13.4 to 8.9 per 100,000. By 2030, the goal is to increase the rate of colorectal cancer screening from 65.2% to 74.4% of all adults. But 2020 brought us a major roadblock. The COVID pandemic resulted in a roadblock to screening for and hence detecting colorectal cancers and all cancers in general. Here's a report from JAMA tracking the rate of diagnosis of new cancers over time. And it found that the weekly rate of newly identified cancers significantly decreased during the pandemic. And the weekly rate of colorectal cancer diagnosis in particular decreased by almost half. Another report from the American Society of Clinical Oncology on the trend of cancer-related patient encounters showed that all patient encounters decreased substantially during the pandemic. And even more concerningly, new incidence patient encounters dropped for all cancers. And this was likely due to a significant drop in cancer screenings during this time. And they concluded that steep decreases in cancer screening and patients with new incidence of cancer suggest possibilities of future increases in patients with late-stage cancer and an increase in demand of cancer screening procedures as delayed tests are rescheduled. Here's an editorial in Science by the director of the National Cancer Institute, which modeled the cumulative excess deaths from colorectal cancer to surpass 4,000 by 2030. So clearly there are clearly long-term ramifications from the pandemic in relation to increased colorectal cancer deaths. And they concluded that clearly postponing procedures and deferring care as a result of the pandemic was prudent at one time, but the spread, duration, and future peaks of the COVID-19 remain unclear. However, ignoring life-threatening non-COVID-19 conditions such as cancer for too long may turn one public health crisis into many others, so let's avoid that outcome. Other major figures have certainly also expressed concerns about plunging colonoscopy rates. And here's a report published in June on the impact of the pandemic on healthcare professionals, which showed that healthcare professional services fell by 68%, resulting in a 48% decline in revenue, and that oral surgery and GI in particular were hardest hit. By April of this year, utilization in GI decreased by 77% and revenues decreased by 80% compared with the same months in 2019, especially since all endoscopic procedures at that time were deemed to be aerosolizing. And this led to published guidance on safely reopening our endoscopy centers. And this guidance statement also published results of a survey showing dramatic decreases in income among GIs, decreases in face-to-face encounters, decreases in endoscopic procedures, and an increase in telemedicine encounters and a widespread shortage of PPE. Meanwhile, a white paper was published by the AGA laying out a potential roadmap for future colorectal cancer screening. Though the guidelines seem to be unrelated to the COVID pandemic, it was certainly published in the thick of the pandemic in July of this year. Pertinent to the pandemic itself, in the guidelines, it's hard to miss their emphasis on a paradigm shift towards non-invasive and minimally invasive tests for screening. And they even suggest a risk-based algorithm similar to some European guidelines suggesting starting with non-invasive testing for low-risk patients. But going back to decreased screening rates during the pandemic, there is a movement towards reviving GI endoscopy in the COVID-19 era. We all know that colonoscopy is the gold standard for screening for colorectal cancer, and it's the only method to both detect and prevent colorectal cancer by finding and removing polyps, and it has a proven benefit of decreasing both the incidence and the mortality from colorectal cancer. But as endoscopic procedures have decreased during the pandemic, and with an increase on non-invasive screening methods, it's inevitable that the significant operator dependence and high variability of quality metrics among endoscopists will be increasingly emphasized, especially since these quality metrics have been so clearly tied to colorectal cancer outcomes. In this study from 2010, a landmark article in the New England Journal showed that increases in ADR correlate with decreases in interval colorectal cancer. And in this landmark study from 2014, it showed that increases in ADR correlated with decreases in interval colorectal cancer, decreases in advanced stage interval colorectal cancer, and decreases from mortality from interval colorectal cancer. And more recently, in 2020, they redemonstrated the same benefits in interval colorectal cancer rates, decreasing those rates in both average risk and high risk patients in colonoscopists who have higher adenoma detection rates. So this data has led us all to wonder, how can we increase our adenoma detection rate? And many strategies have been proposed and proven to do so, including increasing withdrawal time, improving prep quality, improving techniques during colonoscopy, such as water exchange and water immersion techniques, retroflexing in the right colon, And finally, improving our withdrawal technique. And this is where assistive devices, such as the Endocuff Vision, have been proven to help. And I'll explain how. Kelsey, is my audio okay now?
Yes, actually, I don't hear any feedback. So yes, you're good.
Thank you.
Mhm.
So we as endoscopists all know that there's a fine balance or trade-off between adenoma detection rate and withdrawal time. And any of us could theoretically have a perfect adenoma detection rate if we were theoretically able to spend unlimited time in the colon looking for polyps, and correspondingly, the shorter we spend, inevitably at some point, our adenoma detection rate will decrease. So why did I choose to incorporate the Endocuff Vision into my practice? Well, I wanted to maintain my high ADR and hence offer the best care to my patients without requiring such a long withdrawal time. And I also wanted to find a way to sort of distinguish myself as a provider of the highest quality screening exams. And I thought I could do so by marketing myself as a high detector. But the concept is a bit obscure and abstract and also a bit difficult to validate. But with the Endocuff Vision, I'm able to market myself as a provider of augmented exams that result in a high adenoma detection rate. Let's talk about the clinical data supporting the Endocuff Vision. The data is robust. There have been over 60 clinical articles and studies published, including 7 meta-analyses and 16 randomized controlled trials, which have resulted in 9 approved claims based on the clinical data, which is that the Endocuff Vision results in a statistically significant and clinically relevant improvement in the adenoma detection rate as compared with unassisted colonoscopy. The device was designed and manufactured in the UK, and hence it's been incorporated very quickly by the UK national guidelines, which are called the NICE guidelines. These are evidence-based guidelines for healthcare in England, and the National Health Service in England has funded over 90,000 units of Endocuff Vision for 2 years in a row to promote the adoption and increase the usage of Endocuff Vision in colonoscopy procedures throughout the UK. And they made the statement saying that using Endocuff Vision is cost saving. Savings are related to the increase in adenoma detection rate. And for a colonoscopist with a baseline adenoma detection rate of 51%, which is quite high, using Endocuff Vision saves 53 pounds per patient over 10 years compared with standard colonoscopy, which certainly adds up in a huge cost savings. I'll go over a few of the studies that have proven the efficacy of the device. In this first study in France from this year, 2020, it was a randomized crossover trial of 2 teams of 11 endoscopists each, which showed that the adenoma detection rate increased from 29.4% to 39.2%. That was statistically significant. And that was irrespective of which team used the device first. Interestingly, they found that the increase was significant only in physicians classified as high detectors, which is actually different from most of the other studies, showing the most benefit in low detectors. In a UK-based multi-center randomized controlled trial of 7 hospitals and over 1,700 patients, they found that the adenoma detection rate increased from 36.2% to 40.9%, and that was statistically significant with no adverse events found. And they found that the Endocuff Vision facilitated quicker colonic intubation and was non-inferior in all aspects of patient comfort, other than minimal discomfort on anal intubation, which we'll talk about in a bit. In an interesting trial by Doug Rex in Indiana, this randomized controlled trial was interesting in that it was in only 2 experienced endoscopists who presumably have already a very high adenoma detection rate, who were aiming for a thorough exam, but in the shortest time possible. And they found that between the 2 groups, the insertion time was no different, but the withdrawal time was significantly shorter at 6.5 minutes versus 8.4 minutes. And yet the adenoma detection rate and adenomas per colonoscopy was no different between the 2 groups, which shows that in endoscopists who are already high detectors, the device can offer significantly shorter withdrawal time without a compromise in the ADR. In a meta-analysis from 2019 of 9 randomized controlled trials that were pooled, they found that the adenoma detection rate was statistically significantly increased with a relative rate of 1.18. And in particular, among endoscopists with a lower adenoma detection rate of less than 35%, the RR was 1.37. And so they found that there was a statistically significant improvement in the adenoma detection rate among those pooled studies. So looking back at the trade-off or the balance between adenoma detection rate and withdrawal time, the endocuff really helps achieve that balance or that sweet spot, helping us maintain a high adenoma detection rate without requiring excessively long procedure times or withdrawal times. In my experience, I've found that the endocuff vision certainly increased my polyp detection, especially behind folds, flexures, behind the ileocecal valve, and in general, locations that are difficult to visualize. It certainly helped me decrease my withdrawal time without affecting my adenoma detection rate. And another benefit that's not widely published is scope stability achieved with the endocuff vision. The device allows us to achieve better scope stability, especially during polypectomy. And examples of that include maintaining visualization of a polyp while we're passing the catheter, the snare catheter down the channel. I think we've all have seen those frustrating times when we lose the polyp while we're passing the catheter down the channel. And this has significantly decreased the rate of that for me. It certainly helps during the time of polypectomy itself, and certainly helps with stability during inspecting the post-polypectomy margin. When I bring patients back after a polypectomy or an EMR to inspect their scar, the endocuff vision certainly helps me inspect their scar. Contraindications to the procedure include acute or severe colitis, diverticulitis, a known colonic stricture, when deep ileal intubation is required, or other complex procedures such as ESD when a separate distal attachment is required. Are there minor clinical downsides? Yes. Scope insertion may be ever so slightly more difficult, especially in a tight or tortuous sigmoid colon, since the diameter of the scope is slightly increased with the device. There can be some discomfort during insertion through the anus. And an example is of a patient that I have who is a physician himself. And I performed his colonoscopy last year with the endocuff. He happened to have a tight anal sphincter and did have some discomfort on insertion of the device. But with the device, he decided to have his procedure without sedation. And he witnessed firsthand that I detected a large flat polyp behind a fold, likely with the assistance of the endocuff. And I removed it at that time. Then when I repeated his colonoscopy this year, despite him having a history of some anal discomfort upon insertion with the device, he actually asked me to use the device again because he witnessed firsthand that the device helped me detect this large flat polyp behind the fold. So in general, the benefits greatly outweigh the risks, as you'll see. Intubation of the terminal ileum can sometimes be difficult, but over 95% of the time, I'm able to visualize the very end of the TI and even take biopsies if needed. Most studies have indicated a device removal rate of 3 to 4%. In my personal experience, my device removal rate is less than 1%. I have found some techniques to mitigate the difficulties, including applying copious lubricant on the device as well as the distal end of the scope, using the water immersion or exchange technique during insertion to help sort of lubricate the scope, using small back and forth motions or kind of a jiggling motion in tighter or tortuous areas. In patients with a tight anal sphincter, I've found that using steady and gentle pressure and small circular motions during insertions have certainly helped. And in patients in whom I need to intubate the ileocecal valve, Using copious water and a gentle, steady pressure or small back and forth motions when I'm pressed up against the valve I found certainly have helped. In my practice, I use the Endocuff vision during most, if not all, screening and surveillance exams, during specialized polypectomy exams and EMR when it's needed. I encourage my patients to have their exams unsedated so that they can witness the benefits firsthand, especially the patient I mentioned to you who is a physician, and healthcare providers absolutely enjoy watching their exams, especially when I use the Endocuff device. I do use the device in patients who come to me for evaluation of lower abdominal pain, rectal bleeding, or change in bowel habits, as pathology in these patients, if any, is usually colonic. However, I do try to avoid using the device in patients with the known or even suspected inflammatory bowel disease, and even in patients who are in known remission from their inflammatory bowel disease, as I almost invariably want to and need to intubate their ileum deeply. In patients who need an evaluation of diarrhea, weight loss, melena, or anemia, I will often need to intubate their TI. So I will usually not use a device in those patients. In patients with known severe diverticular disease or with the tight or tortuous colon, I'll avoid the device. And similarly, in patients with recent episode of diverticulitis, I'll avoid using it just in case there's some residual inflammation. I'll still use the Endocuff vision in patients who come to me with a quote unquote history of a tortuous or redundant colon described by another endoscopist, unless they describe it as severe. And in those patients, almost 100% of the time, I'll still be able to intubate the cecum without having to remove the device. So incorporating this device in my practice and seeing the benefits of increases in polyp detection and adenoma detection rate, decreases in withdrawal time, and really just allowing me to provide the highest quality exams to my patients just reminded me of other technologies that have become the standard of care. And now that I've used the device thousands of times over years, I really do strongly feel that there should be a movement towards making Endocuff vision the standard of care. And let me remind you of a few other technologies or techniques that have now become standard of care, which have actually reminded me of the evolution of that Endocuff vision that we're seeing right now. So as I'm sure you remember, in 2010, there was a study showing that comparing high definition colonoscopy versus standard definition resulted in an increase in polyp detection. And that was again proven in 2016. And high definition colonoscopy has now become the standard of care. Similarly, in multiple studies, split dose bowel prep has been shown to increase adenoma detection rate, and this has now become the standard of care in colonoscopy. So similarly, most technologies that have proven increases in ADR are not widely recognized as standard of care, since there are similar devices out there, but that's mainly, in my opinion, due to cost barrier. But I have found that this out-of-pocket cost-shifting model allows patients to be involved in their own decision-making regarding a cost-benefit preference, and it allows us to provide the best care and the highest quality colonoscopy exams without the worry of bearing the cost of the device. Thank you very much for allowing me to present this information to you. I would welcome any questions.
Thank you, Dr. Shah. That was great. So yes, we'll be moving into the Q&A portion of the webinar. So attendees, if you haven't done so already, please submit your questions using the chat box at the bottom of your screen. So I'll just give a few minutes for those questions to flow in. Okay, Dr. Shah, we do have one, and I think you may have touched on this a bit throughout your presentation, but the question is, what features of the device do you feel resonate most with patients? And what are patients' biggest concerns about the device, if any?
Yeah, great questions. So I think the features that resonate with patients really have to do with minimizing the chances of missing a lesion, minimizing the chances of missing a cancer, and minimizing the chances of developing cancer between now and the next colonoscopy, which is called the interval colorectal cancer. And so the device really resonates with them in that it maximizes the detection and visualization of the exam. The biggest concerns I have really have to do with safety. And fortunately, there have been zero major safety concerns in pretty much all of the studies with Endocuff vision showing a zero increase in serious adverse events from the device.
Thank you, Dr. Shah. I'm just reviewing a few more questions that are coming in. One question is, are there any high-risk groups this should be considered for? Right-sided polyps, basically beyond ADR.
Yeah, great question. So I have many patients with serrated polyposis syndrome, many patients with Lynch syndrome, many patients with familial adenomatous polyposis syndrome, or patients who have just had many polyps who test negative on their genetic analysis. And it's really in those high-risk patients, I think the device is highly effective at finding polyps in those patients in whom I pretty much know that there are polyps going to be there, but they potentially are very difficult to detect. It is not infrequent for me to see a patient who has had multiple colonoscopies by other endoscopists and have had multiple negative colonoscopies with no polyps over consecutive exams. And I will do an exam on them using the device and will not infrequently find multiple polyps, which were probably previously hidden. And some of, not infrequently, are these polyps large or flat, and they're almost always hidden behind a fold or behind a flexure. So certainly in these high-risk groups, the device is probably even more beneficial than the average risk screening population.
Great, thank you again. And just one more here. See, we're getting a couple questions through the Q&A and then also the chat function. So I'm just trying to sift through here. What is your opinion about multiple polyposis versus surgeries?
I think the question has to do with removal of many polyps versus doing surgery for patients who have many polyps. And really, in this day and age, there are very, very few indications to perform surgery for benign adenomatous polyps, really irrespective of the size and almost irrespective of the location. So almost any polyp of any size or location can be removed via colonoscopy. And very few polyps now need to be removed by surgery. Even if a patient has dozens of polyps that can also be removed by colonoscopy, it might take a few sessions, but it certainly can be done. So there are fewer and fewer indications to perform surgery for benign adenomatous polyps.
Okay, great. Thank you again, Dr. Shah. And I think, just sifting through again, I think that about concludes most of the questions that have been asked. So again, thank you so much for your time. And I know that we are wrapping up a bit early, but I'll just give a few more seconds here for some more questions to come through.